Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a very hard cataract, and in this case I have planned large incision cataract surgery. We may call this double SICS. Two SICS wounds will be placed side by side to get a large wound of about 10 millimeter. After placing the superior rectus bridle suture, conjunctival peritomy is done for about 3.5 clock hours. This is the peritomy. Starts from about 10 o'clock to 12 o'clock. The underlying tenons is also dissected, and now from 12 o'clock the peritomy is enlarged up to 1:30 o'clock. So about 3.5 clock hours of conjunctival peritomy. And before using bipolar wet field cautery, please clean all the tenons tissue from the scleral surface. Otherwise this tenons tissue will contract, it will form a membrane over the sclera, and it will cause hindrance in making your sclerocorneal tunnel. So this is the tenons. It is being nicely dissected from the scleral surface and it is trimmed. And now we have got a large wound, large area for making the sclerocorneal tunnel. This is bipolar wet field cautery. Very mild application of cautery is done. Care is taken not to cause any charring of the scleral surface. And now the very important step. Two SICS wounds will be placed adjacent to each other. Just note this. This is the first SICS wound, and this is the second SICS wound, and we will place a suture joining these two SICS wounds at this place. So, and rest of the steps are just as in SICS. Now you may ask me, why this kind of incision, why not a frown incision? Just think about this. If we want to get a frown incision of about 10 millimeter, how far back we have to go and how difficult it will be to make the sclerocorneal tunnel. So this is a easy way to do the surgery, and I hope any surgeon can do this. Any SICS surgeon can do this. And the placement of suture at the junction of these two SICS wounds, or we can see at the apex of this V-shaped incision, will not allow to cause a large amount of astigmatism, because the wound will not be gaping. It will be, the wound margins will be opposed to each other because of the single suture. Sclerocorneal tunnel has been made, and now I'm going to make two side ports in this case. This is one side port at 8:45 o'clock, and this is another sideboard at around 3 o'clock. And now I want to stain the anterior capsule of this cataract with trypan blue dye to get some contrast during Capsulorhexis. An air bubble has been injected, and beneath this air bubble, this is trypan blue dye. This is a good practice to eject some fluid, whatever you are injecting inside the camera. Just eject it outside the eye and see what you are going to inject. If you have this practice, you will not inject a wrong agent inside the eye. So this is washing out of the dye. This surgery is going to take a long time. So please have patience and watch this surgery. And it is not a difficult surgery, but a lot of judgment, a lot of common sense goes along with each step of the surgery. This is visco 2% hydroxypropyl methyl cellulose. After injecting this visco, I am going to do Capsulorhexis, and this is a 26 gauge bent needle cystotom. The anticapsule is incised, capsular tag is raised, and now I guide this capsular tag. I have started from 10 o'clock, now it is at 9 o'clock, and now I am pushing this capsular tag towards 6 o'clock. I am taking care to do a large rhexis so that nucleus prolapse becomes possible, nuclear prolapse becomes easy. Now this is some more visco, and now I'm going to push this flap again, but I am finding some difficulty with this cystatum. So what I'm going to do is I'm going to use a utrita forceps now. Inject visco, take the keratome 2.8 millimeter keratome and make a 2.8 millimeter entry. And now I take the utrata forceps, hold this capsular tag, yes, the utrata goes in, holds the capsular tag, and now the rhexis is being completed. And this is a fairly adequate sized Capsulorhexis, and I am hoping that the nucleus will come out of the capsular bag easily. And now visco again to fill up the anterior chamber. And now the sclerocorneal tunnel is being opened from one end to the other end. Always cut when you go forward so that there is a very nice corneal valve and this is actually a self-sealing wound, but I am going to put a suture to hold the two SICS wounds and to reduce astigmatism. And this is hydrodissection. Now the nucleus is larger in size than the rhexis, so it is not coming out of the capsular bag by hydrodissection. In such cases, we can take two Sinskey hooks and bring out the nucleus from the capsular bag in this way. Yes. One hook remains behind, the other rotates the nucleus, and it comes out of the capsular bag. Now visco both in front and behind the lens mass. And now this is the irrigating vectis. Go behind, and since the wound is large, it comes out easily. And now a lot of cortical matter is remaining in the capsular bag. I have to remove that. So I inject visco again, 2% SPMC, and now the cortex is being removed. And now I'm taking care of the capsular bag. I don't want to pull it vigorously and tear off the zonule. I'm going through the left side port and remove the cortex from 8 o'clock, 9 o'clock, 10 o'clock, 12 o'clock. Nicely removed. So the left side port has been extremely useful in this case. In this case, we have selected a sensor multipiece intraocular lens, and we don't have to fold the intraocular lens. The lens will go as it is. This is 2% hydroxypropyl methyl cellulose. The bag and antechamber is filled up, and now I take the lens, sensor multipiece intraocular lens from Abbott. We can use single piece lenses also in this case, but this is a universal lens. We can place it in the sulcus, in the capsular bag. That's why I selected this lens. The leading haptic goes into the capsular bag, and the trailing haptic also goes into the capsular bag. This is a beautiful lens. And now some visco, and now I'm going to put a suture joining these two SICS wounds. Before that, the ocular surface has been thoroughly irrigated. Dear colleagues, this is an almost unedited surgery, very minimally edited surgery, and you are not missing anything of the surgery. (10O) nylon suture is taken. And only one suture is being placed at the apex of this V-shaped incision or at the junction of the two SICS wounds, whatever you say. I'm going to tie this knot. This is going to be a 2-1-1 suture. First 2 throws, then one, then another one. See, this is 2 throws. 1, 2. And we have to be very careful. We don't have to pull it very vigorously. Just want to oppose the margins of the wound. Friends, 10O nylon suture is a delicate art. Feel proud if you can master suturing very nicely. Whenever a corneal perforation comes as an emergency in your clinic, you will be very confident to manage the case. If you are good at suturing corneal wounds or sclerocorneal wounds. Now I'm going to place a releasable suture at the right end of the conjunctival peritomy to oppose the conjunctiva to the limbus. Just I'm going to place it, and then I'm not going to tie it now. And now I'm going to remove the visco from the anterior chamber. It is very important to remove the visco from anterior chamber and capsular bag. Yes, not only from anterior chamber, but also from the capsular bag, because lot of retained visco may be there behind the IOL. So we must always go behind the IOL, irrigate for some time, and then aspirate. And thus we must remove all the visco from the anterior chamber as well as from the capsular bag. So this is almost done. This is a bit of moxifloxacin. And now I'm going to tie the releasable suture. It is very easy, just 3 loops. Hold the thread and pull. And now cut the long thread with the needle close to the knot. Keep the other thread longer. And now this is subconjunctival injection of gentamicin and dexamethasone. This is to oppose the conjunctiva to the limbus. This chemosis will help in placing the conjunctiva to the limbus. And we are done. This is final formation of the anterior chamber. Now I check the intraocular pressure, it is fine, and it is done. Now let us see some post-op pictures after 20 hours. Conjunctiva is nicely opposed, pupil is round, cornea is clear, antechamber is quiet, intraocular pressure is 14 mm of mercury, unaided vision is 6/12. Thank you very much for your attention. Hope this video will help you in managing your supra-hard cataracts where you may not be willing to do phacoemulsification. This is a very safe surgery and you can definitely try this.